I'm Grace Halsey, Senior Editor of Patient Care Online. And today we're going to talk about what can be a significant challenge for clinicians who are treating patients with the disease of obesity. And that is opening the conversation about bariatric surgery as the medically necessary next step in the process of managing the disease. And I'm emphasizing necessary next step because, as we'll talk about with our guest today, that context can be in direct conflict with the widely held idea that bariatric surgery is the step of last resort. So to talk more about clinician and patient barriers to starting a positive dialogue, I'm speaking today with Dr. Gretchen Ames from the Mayo Clinic Bariatric Center in Jacksonville, Florida, where she is a psychologist in the Bariatric Surgery, Medicine, and Surgery program. Good morning, Dr. Ames.
Good morning. Thank you, Grace, for having me. I'm so excited that we get an opportunity to talk about this topic. I'm really passionate about it. I'm very fortunate that I get to work with a team of professionals. Our center actually has a bariatric medicine physician, so we can look at the medical side and surgical side of treatment for obesity. We also have a physician assistant, 2 dietitians, a nurse coordinator, 3 surgeons, and me, which is great. The team approach works best, I think. And most of our referrals are patients with a BMI of at least a 35. So that is severe obesity. And we get referrals from all over the clinic, really solid organ transplant for specialty care, orthopedics, cardiology, endocrinology, but we also, I think, partner very nicely with our primary care physicians in giving them support and them helping treat their patients struggling with severe obesity. And for my part of it, I do the psychology evaluation for bariatric surgery. And really, I mean, it's a psychology evaluation, but a lot of it is just sitting and talking with patients about, is this decision to have bariatric surgery the right choice for them?
Mm-hmm. So a BMI of 35 or greater is definitely part of the criteria, but are there other things that are taken into consideration when you're counseling somebody about bariatric surgery?
Yes, definitely. Probably in the last 10 years, the most important thing that we've learned about bariatric surgery is that it is the best treatment for diabetes for any patient who has a BMI over 35. So diabetes, cardiovascular disease, hypertension, sleep apnea, those kinds of things. So if you have a patient who has a BMI of 35 and those issues, then surgery should probably be on the table for discussion. Also, if your patients are suffering from mobility problems, they're having a harder and harder time getting around, declining quality of life. When I meet patients in their 60s and beyond, probably the most important thing to them is being able to maintain their independence and be able to live well and not have to rely on other people to take care of them as long as they possibly can. So they know that losing weight is going to enhance mobility and quality of life. If you have a patient who's done repeated cycles of dieting, that is, they've been able to lose a certain amount of weight, maybe they've done this multiple times, but regained it. They'll make a weight loss effort and then regain it and struggle. That is a perfect person also to consider for bariatric surgery. And I'll say one last thing before you go too far down the road of bringing up bariatric surgery and getting someone excited about it. It is an important step to verify that they have an insurance benefit for it. Because if it's typically out of reach financially if it's a cash pay situation. So having your patient check their insurance to make sure they have that benefit is important too.
Oh, goodness. So you've written very extensively about the barriers to having this very first conversation, and maybe it is that patient who has been yo-yoing or on the roller coaster of weight loss, regain. And there are barriers to having the conversation on both sides. Physicians may be reluctant to bring it up, and patients may be reluctant to bring it up. What are the thoughts or the misperceptions on both sides there?
Okay, so we'll start with patients first. I think still bariatric surgery is getting a bad rap. That is, patients consider it to be too risky and too dangerous still.
Mm.
When in reality, for the past, it's not even recent, it's over 20 years that we have been doing these procedures laparoscopically or minimally invasively, which makes it, this improves the safety profile quite a bit. In fact, the upper age limit for having bariatric surgery at our center is 80. Can you believe that? Yeah, so the safety profile has improved that much that we can help a lot more people, especially in later years of life.
Mm.
I think patients are hesitant to think about, I might have to pursue a riskier treatment to get the benefits I want, right? To lose enough weight, to see the improvements in health status that I'm looking for. That for some patients, just diet and exercise is not going to get them there, no matter how hard they try. And it's difficult because most patients still, actually really in our country, the perception is that obesity is caused by eating too much of the wrong things and not moving enough. And for a lot of our patients, it's much more complicated than that. And no amount of diet and exercise is going to help them lose that large amount of weight and keep it off. The other thing that comes up is patients think, gosh, if I have to choose bariatric surgery, then I'm giving up or I'm taking the easy way out. Actually, the opposite of is true. If you ask a patient about their experience with bariatric surgery, there is nothing that's easy about it. It's a lot of hard work and dedication, and it is a commitment to lifelong lifestyle change if
Right.
they want to be successful. Because we've all heard stories of people who've regained weight after surgery, and certainly that can happen. About 20% of patients will struggle with pretty significant weight regain. But most have a really favorable outcome in the long term. Other thing that happens with patients is it takes them a long time to be able to admit to themselves, I need help,
Mm.
and be okay with it, right? Because if we still perceive it as a lifestyle problem, then asking, I should be able to do this on my own. I just need to work harder, have more willpower, and that isn't always the case. So that's patients. I'll
Right.
move into providers.
Mhm.
They do have some of the same issues. I think some providers are worried that it is risky and dangerous, but the safety profile for the surgery, now that it's become laparoscopic, is very similar to having your gallbladder out.
Ah,
And I'm not sure that not a lot of providers know that.
sure.
And it puts patients at ease to give this kind of information to them. Um, I think maybe providers, and the literature has shown this somewhat, they overvalue lifestyle change, diet and exercise, and then they also overestimate the risk of surgery. So when in doubt,
Mm.
it is easier to go for the lower risk option, and patients may feel more comfortable with that. I think providers don't often understand this process that's called metabolic adaptation to weight loss, which is one of the reasons and biologically why people struggle to keep weight off for the long term. It's not a willpower issue. It's the human body is designed to put on fat and resist against losing it. So
Right.
people really struggle with keeping large amounts of weight off. Um, I think providers too can get caught up in metabolic syndrome, right? Because
Mm.
there are medications for blood pressure, for blood sugar, for cholesterol, lots of different ones. You can add more than one. There's a sleep apnea machine that will help with that. And instead of viewing obesity as a disorder of the system, it's more treated by the individual problems that are arising, and then patients can then end up like on 6 different medications for different problems.
Mm.
Whereas the surgery for someone with a BMI of 35 or greater, the surgery could put all of those things into remission, get them off of their medication, and also perhaps get off the CPAP machine.
Mm. Right.
Yeah, so that's some of the things that I think are going on. Couple other things with providers. If a provider's if they don't have a lot of confidence in their knowledge about the surgery, they may be hesitant to bring it up, or they're fearful of being asked questions that they don't
Mm,
know the answer to. None of us likes that, right? We don't
mm,
want to be asked questions that we can't answer. Um, and then when patients express ambivalence, which is kind of feeling two ways about things, yeah, I know I need to lose weight, but everything I've done hasn't worked. So why should I bother doing this again? Because I'm going to end up in the same place. And there's maybe providers don't have a lot of tools for dealing with that conversation.
mm.
So just some of the things that I think are happening.
I think I read something interesting in something that you wrote about a study. I think the study was in 2018, where I think it was even providers who were studying to take their obesity medicine boards still believed that lifestyle alone would be more effective than either medication or surgery, which
Right.
sounds like a very big educational gap, knowledge gap.
Absolutely. Now, um, we could, of course, look at by BMI category. If you have someone who's in the overweight range, that might be absolutely appropriate. So that's a 27 to a 30.
Hmm.
A BMI of 30 to 34 gets a little trickier because the patient is getting a little sicker with health problems. It's a little harder to lose weight, but they're not appropriate for bariatric surgery at a BMI under a 35. So those patients kind of fall through the cracks a little bit, I think, because you can obviously you want to recommend lifestyle change because that's the kind of the cornerstone of all treatments. But it certainly isn't going to work for everybody. So I think where the educational piece really would be helpful is for people who are struggling with that BMI of 35 or greater. And also that same study talks about prescribing medications. I think those are underutilized. There are several medications out there now that um, are approved for treatment of obesity, but even in our clinic, everybody gets referred to our obesity medicine provider. Nobody else wants to deal with it. They just say, "Oh, go see him. He'll take care of it."
Huh.
So there's some reluctance because it's a chronic thing, right? You have to prescribe it and follow these people for the long term.
I think
So
you just raised something that I think too may be difficult, especially for the primary care physician, which is the follow. This is a process. Obesity, and especially morbid obesity, it's a disease like diabetes. It's something
mhm.
that is metabolically, the underpinnings are metabolic, and to say, okay, do this for 6 months, get better, and bye, just doesn't work. But I think it's frustrating also, certainly at the primary care level.
Oh, absolutely. And heading into anything with a temporary mindset, that's kind of, I talk to patients about this all the time. Diets are kind of doomed to a poor outcome because we set out in the mindset is that it's temporary. Well,
Mm,
then what, right? You can put up with any amount of suffering for a little bit if you're starving and miserable on this diet.
right.
But if it stops working, and you start regaining weight, there is no one on the planet who's going to keep doing that plan. So in regarding education, a couple other areas too I think are important. Learning more about this metabolic adaptation process. So when a patient loses 50 pounds or more, what's going to happen when they get to that endpoint is they are going to have to have an indefinite calorie restriction that's really, really hard to sustain. And they will also have to have an extremely high level of physical activity to keep that weight off. We're talking at least 90 minutes a day of cardio. That's what the research shows. So there is really no one, it just doesn't fit in the world that we have today. And so then people start regaining because they can't sustain this effort and they blame themselves. It's a willpower issue. Why can't I do this? And then they kind of end up feeling hopeless about it and maybe give up for a little while. And that's where certainly if they have a higher BMI, where the surgery conversation could come in. So if a provider is stuck in just prescribing lifestyle change, then certainly more education would be a helpful thing.
And so for a provider, a primary care physician who's been working with somebody for 18 months or so, they've got diabetes, they've got, mild heart disease, if there's any such thing as mild heart disease. When is the right time to open the conversation or to refer?
Certainly if what you're doing isn't working, right? And you're having to perhaps add more medications, or the patient is telling you, I'm doing this, I am trying this, it's not working, believe them. It's that simple. Just believe what they're saying. And where would you like to go from here? We can kind of keep doing what we're doing. I know you don't want to add another medication into this. Should we consider some other options at this point? What do you think about that?
Okay. I was going to ask if there were 3 things, thoughts or suggestions that you could leave our primary care physicians with today. You've mentioned so many good things, but maybe 3 simple things for them.
Sure. Just what I was saying was my number one. It goes against everything we're taught as providers. Resist advice giving. It's really hard. Spend 5 minutes. All it takes is 5 minutes of listening. Make sure that you have an understanding of, okay, when did this patient's struggle with obesity start? What were some triggering events? How have they struggled? Was it childhood? Was it later in life? Was it pregnancy? That happens for a lot of women. So understanding when they first started to struggle with their weight, what have they tried? Figure out what are the things that they have already done, because what patients like the least is to be told things they already know. They will lose confidence in you very quickly. They will feel like they don't have, the trust isn't there. They've lost their autonomy. You start giving advice and telling them what to do, and there are things they've already done that can be kind of damaging to the relationship. So if you can resist walking in with advice giving and just take 5 minutes and listen to what this patient's story is, it's really helpful. Number 2, have a clear understanding of what is worrying your patient the most about their health. Is it the loss of mobility or independence? Or, gosh, you know what? I have to get to a BMI of 40 before I can have my knees done, and I can't exercise at all because my knees hurt so bad. But how am I going to lose weight if I can't move? Figure out what is most important to them. This one comes up a lot. I don't want to go on insulin. I just don't want that. I have seen the long-term consequences of diabetes. I don't want that for myself. I don't want to take 3 or 4 different medications for blood pressure. If you can tap into the patient's motivation, you're going to be able to move that conversation forward a lot more quickly. And number 3, if you're standing outside the room your patient's in, and you pick up the chart and you see a BMI of 35, consider, is this the right time to bring up the idea of considering bariatric surgery? Even before you go in, how could you spend a little bit of time listening, and then, okay, what we're doing maybe isn't working as well as some other things could. Are you open to having a discussion about perhaps bariatric surgery? The last thing I will say, in a lot of communities, if you want to refer a patient for bariatric surgery, there are centers with that have an excellence designation. They have the best outcomes, the most experienced surgeons. And I'm going to read this so I don't get it wrong. Look for a metabolic and bariatric surgery accreditation and quality improvement program. So if the center has that designation, you can be pretty certain that it's the highest quality and feel good about sending your patient there.
Excellent. And yeah. Good advice, and so hard to not give advice.
It is. I find myself doing it all the time. Like, I have the best ideas. No, you don't. The patient probably has the best ideas. They've been living this life, and you can get a lot just by doing a little bit of listening.
Okay, thanks so much, Gretchen.
You're welcome. Thank you for having me.